sessions of video lectures is two videos. One is on ramp lesion repair and the other one is on radial tear two tunnel technique repair. The first presentation is on ramp lesion repair and what are the tips and tricks that I follow in my practice. This is my profile in brief. We all know about ramp lesions. They are meniscocapsular separations. They have been described in detail in these review article recently by Robert Laprade, and I would suggest all of us to go through this article. The incidence is anywhere between 30 to 40% of all ACL reconstructions, and this is what we see corroborating in our practices also. Almost around 30% of tears, especially when chronic, we see that they have these ramp lesions. These are missed if you do not do the evaluation through the posteromedial pouch and through the posteromedial portal. And this is what we're going to discuss in this presentation. So as I just said, ramp lesions are nothing but meniscocapsular separations. Ramp is the normal area of the meniscus. Whenever there is a tear in that area, we call it as a ramp lesion. This has been very well classified by Sandri Cote from Lyon, France, into 5 types. Type 1 is just a plain separation, and we see small rents in this area in quite a few cases, which are usually stable and don't need any repair. Type 1 is when it is involving the meniscocapsular junction and with a small tear. Type 2 is when there is a partial superior lesion. Type 3 when there is a partial inferior lesion. Type 4 is what is the typical tear which requires various tips and tricks, and that is what we're going to be discussing here, where there is a through and through tear at the meniscocapsular junction. And type 5 is when there is a double tear. So with this understanding of the classification, we need to know on the MRI, this can be picked up with this sort of a longitudinal signal at the level of the root and the meniscocapsular junction, usually associated with posterior medial tibial plateau edema. That should be the indicator for you to understand to look for ramp lesion arthroscopically. However, we are doing this in every case now. This is the Gilkish view. We go between the PCL and the medial femoral condyle. This is the right knee. In every case, we enter this posteromedial pouch, drop the knee to 90-degree flexion, get a needle from the posteromedial corner, and use this needle test in every case to make sure there is no ramp lesion. In situations where there is a tight knee, for example, this is the left knee which is extremely tight and it is difficult for me to enter the posteromedial corner. So what I do is I clear some of the soft tissues, shift the scope from the anterolateral portal to the anteromedial portal, like so, get a switching stick from the anterolateral portal, pass it through the area between the medial femoral condyle, PCL, and the medial tibial spine, railroad the arthroscopy sheet through the switching stick, and then you can enter the posteromedial corner. So these are the tips and tricks for the entering the posteromedial corner. Sometimes you need to internal rotate the tibia in about 30-degree flexion and try to slightly force your way in. This maneuver of internal rotating the tibia subluxates the posterior tibia and allows you to enter this particular corner. This is how typically anterior arthroscopy is done, and you feel that the meniscus is stable. But if you enter, and every case, if you follow this protocol of entering the posteromedial corner, then you will realize that suddenly the incidence of ramp lesions in your practice is extremely high. And this is a classic example, a meniscus that appeared stable from front, but you can see a type 4 ramp lesion where there is a through and through tear. It's very important to now, once you start repairing this, to do the pie crusting. The tips that I follow is I feel for the joint line, use an 18-gauge needle from the TUR set, distal to the joint line and direct it posteriorly like a tenotomy blade with gentle valgus given by the assistant. And like you can see in the video, you will see a very gradual opening and you will not get that dangerous sound if you follow these principles. So pie crusting is important for me in my practice, especially for these large tears which are extending through and through, because I am going to be employing all the techniques available for repairing this meniscus. That is all inside devices, inside out devices, suture lasso kind of devices, and therefore I need a nice visualization space so that there is no articular cartilage scuffing. So with this pie crusting, you will realize that the same tear is now much more visible, much more easily accessible and manageable. It is clearly exposing the posteromedial tibial plateau. Having done the pie crusting, being comfortable about visualizing this entire area, I would now like to share a few tips and tricks regarding creation of posteromedial portal and in fact posteromedial portals, because in my technique I utilize two portals. So this is typically the area in a left knee, for example, how the posteromedial corner looks. Now there is a confusion where you need to create them. I will try to give you a few slides as to what guidelines you need to follow. So if you create a portal that is too low, you risk injuring the saphenous nerve. If you create a portal that is too high, you risk injuring the medial head of the gastroc. So if you look at this triangle, typically from the Gilchrist view, when you enter into the posteromedial corner, you will see the gastroc fold, you will see the adductor fold, you will see the medial femoral condyle on one side and the semimembranosus fold. Now this, for example, is the right knee, and the triangle that forms between these folds, if you are within this triangle, you can be rest assured that you are unlikely to damage the nerve or any other important structures. Another trick is to turn off the OT lights, look for the transillumination, and make sure that your needle comes to the center of the transillumination. This again will help you visualize any nerve shadows that can help you, and you will be in a safe area. Now this is the short video of the technique that I use using the lasso-like devices. So the first spinal needle comes above the capsular fold. The second comes at the level of the joint line. Do not remove the needles, let them be in place. Create a incision. The above incision should ideally be horizontal like you see in this video and above the capsular fold. This allows the portal to be naturally closed by the capsular fold and there will be no synovial fistula. I then come with a small cannula above, something like a 5.5 mm and a switching stick from below. You then get a diamond rasp the capsular side thoroughly, rasp the meniscus side thoroughly, rasp the synovium, then get the shaver, use it in the reverse mode with the suction off, and again create a nice healing environment. Again, pour out some amount of the capsule. You then come with the ramp lasso. This is a fixed angle 25-degree lasso. For the right knee, you will use a left angled device. Pierce the capsular side, then pierce the meniscal side. The advantage of using this ramp lasso is that it comes with a preloaded number 0 fiber stick. So it's firm enough to be easily railroaded, like you will see in this video. And once it is in the joint and touches the saline, it becomes like a fiber wire. Retrieve the suture from the cannula and tie a knot. Preferably tie multiple half hitches kind of a knot. Do not use a sliding knot so that there is minimal abrasion of the meniscal and the capsular tissue. You start from the medial side and then keep progressing towards the midline. So this is a simple lasso-like device, spectrum-like device, which is actually 45 degree. That also can be used if you do not have the special lasso. Pierce the capsular side. When you are piercing the meniscal side, sometimes you might find resistance. You can use the hook probe like a counterforce and push the meniscal tissue to take a nice deep bite. Ethylon will be shuttled for a fiber wire, number 0, and again, a knot is tied. So the idea of doing this first is that most of the times the capsular tissue is fallen down and this has been equated to a Bankart lesion. You need to elevate it up to the level of the meniscus tissue to then progress with other modalities, which you will see ahead. So having done the posterior stitches using the lasso-like devices, having got the capsular tissue to the level of the meniscus, now you can make sure that you repair the longitudinal component which is extending into the body. You can use simple devices like all-inside devices, ideally in a vertical mattress fashion, sometimes in a horizontal mattress fashion. If you want to span a larger area, first tie the superior surface. Do not forget to involve the undersurface. So this is a reverse curved all-inside device, which is going on the meniscal side first, then on the capsular side. And when you tighten this suture, you would have repaired the meniscotibial ligament and restored the meniscal flans. And that's a stable ramp repair using lasso-like devices and all-inside devices. What I more likely follow is using the all-inside devices for the longitudinal component. A few tips and tricks for the same. I place the hook probe from the corresponding opposite portal from the anterolateral portal. You can see the two portals that have been closed now. And the hook probe is pointing into the area where I need to get my needles out. And that is where I would take a safety incision. The safety incision has been clearly guided to us by Robert Laprade. You take a safety incision in the posteromedial area, incise the sartorius fascia first, do the blunt dissection, go in the plane between the behind the superficial MCL. You have a triangle which is formed by the posteromedial capsule in front, the medial head of the gastroc behind, and the semimembranosus inferiorly. Once you identify this triangle, place a spoon there. The hook probe is guiding you all throughout, which is the likely exit point of the needles. With this understanding, another tip is to use low profile cannulas, which can be turned 180-degree. So you can go on to the meniscal surface and to the undersurface of the capsule by turning the cannula. So this is the video of the patient. So you have taken stitches on top of the meniscus in a vertical mattress fashion, as you can see, and now you're coming on the undersurface. So the first needle is passed through the meniscus tissue, drop the knee to about 60-70-degree flexion, and that will allow the needle to come exactly being deflected from the spoon, and your assistant can pull on that needle. The second needle is passed to the capsular surface, again being pulled by the assistant, and you can see restoration of the meniscal flaunch. I tie the sutures immediately so that there is no confusion at the end of the procedure. This is another stitch being passed through the upper surface. It's a horizontal mattress stitch which is being passed, retrieved from behind, and immediately tied. At the level of the root, sometimes I would suggest that you do not use the inside out devices. So right at the level of the root, if you feel there is still a rent left, you can use fast fix device first on the capsular surface, then on the meniscal surface. So you have used the lasso-like devices at the back. You have used the all-inside devices above and below the meniscus, and near the root, you have used the all-inside device like the fast fix. So this gives you a nice, stable ramp lesion repair. So the purpose of the study was to give you the tips and tricks which you need to have for dealing with all varieties of ramp lesion repairs. And if you're familiar with these three techniques, then you can manage most of these complicated lesions. Thank you.